Thank you for joining us. My name is Audrey Hassan, Patient Liaison for the MDS Foundation, and I'll be moderating the presentation today. As we get started, I would like to thank Acceleron, Bristol Myers Squibb, Jazz, Novartis, and Takeda for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answer opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Jane Churpek, a professor and hematology specialist at the University of Wisconsin School of Medicine and Public Health, an MDS Center of Excellence. She's a hereditary cancer expert whose clinical focus is on identifying cancer-prone populations and optimizing early detection and cancer prevention for these individuals. She runs a research program focused on defining the contribution of rare genetic variation on risk of cancer and how inherited variants interact with environmental exposures to contribute to cancer initiation in those at risk. She is also a member of the MDS Foundation Scientific, Medical, and Scientific Advisory Board. I could go on and on with her accolades, but that wouldn't leave us any time for her presentation. So with that said, it is my pleasure to introduce Dr. Churpek.
Welcome to this session. My name is Dr. Jane Churpek. I'm an assistant professor at the University of Wisconsin-Madison, and my area of expertise is adult hematology oncology, and specifically inherited forms of blood disorders and blood cancers. So today I'm going to give you a talk about familial forms of myelodysplastic syndrome. So today we're going to start by going through a patient story. So a patient that is seen in my clinic and how that story unfolds to teach us about familial myelodysplastic syndrome. I'm going to give you an inherited genetics primer and help you understand how we use someone's inherited genetics to understand their risk for MDS and potentially other cancers or health conditions. We're going to discuss some of the familial forms of MDS that are currently known and where we still have a lot to learn, and how detecting a familial MDS syndrome can impact a patient with MDS as well as their family. So let's start with a patient story. This is a 42-year-old woman who comes to see a hematologist because of low blood counts, and she is newly diagnosed with myelodysplastic syndrome. As many patients in this situation, some of the first questions that she has are, well, what is MDS, and why did this happen to me? So for those of you dealing with this disorder, you know that myelodysplastic syndrome is a bone marrow disorder or cancer in which the bone marrow no longer makes enough healthy blood cells to support life normally. The major health risks from this disease are bone marrow failure, where people run into trouble because of insufficient blood cells to do the jobs that they're supposed to do, like developing infections from a low white blood cell count, or anemia, symptoms of anemia like shortness of breath because of low red blood cells, or bleeding because of low platelet counts in the blood. The other major health risk is a progression to acute myeloid leukemia, which is a life-threatening complication. So in order to get this diagnosis of myelodysplastic syndrome, her hematologist looked at her blood under the microscope. So here you can see this is what a typical blood smear looks like when we're looking at the red blood cells here and different types of white blood cells. And sometimes their appearances can give us a clue that the patient likely has myelodysplastic syndrome. To further diagnose this, however, we do a bone marrow biopsy and we look at the proportions of fat versus blood cells that are in the bone marrow and how their appearances, do they look normal or do they look abnormal? Then we also perform a number of other tests like the karyotype, where we actually look at the cell's chromosomes at this zoomed out level and count them and see if any are missing or extra parts are present. We also sometimes do tests like this one called FISH, where these little signals tell us how many copies of each chromosome that we're interested in are present in the cell. So this is a technique that we can use to detect common changes, like a deletion of chromosome 7, where we would maybe only see one signal inside a cell instead of the expected two. We also do other tests like gene sequencing, where we're actually reading the letters of each gene of interest that helps us understand the type of MDS, the prognosis, and sometimes helps with treatment decision making. So how does this happen? Why does someone develop bone marrow failure because of myelodysplastic syndrome? Well, our bone marrow, which is highlighted in these red areas in adults, so inside these bones are the factory where our blood cells are made. And this representation here shows a number of the blood stem cells. These are the mother cells that help us make all of our different blood cells. And we have lots of these mother cells that live in this bone marrow. And over time, as these cells are dividing and helping produce all of the blood cells that we need every day, errors happen in these blood cells' DNA. So these colored dots are sort of a representation of an error that happened during that cell's lifespan. And those errors can happen just because of when a cell is dividing, it has to copy its DNA. And sometimes by chance, an error happens and that can persist in that cell. Other things like exposures, so if someone is smoking or has an exposure to a chemical like radiation or other specific exposures, that can increase the chances that a stem cell will have a potential damage event. So this diagram now shows, let's say one of those errors that happened in the DNA actually makes this stem cell grow better than all of the rest of the cells. You can kind of think of it like a garden. So when you have a plant or a weed that potentially can somehow outcompete the other plants in that garden, it potentially can take over your garden. And so that's sort of how this process works. So if one of these genetic changes here actually makes this particular stem cell grow and divide faster than the others, it can make a bigger proportion of your body's blood cells. And at first, this process does not necessarily constitute myelodysplastic syndrome or a blood cancer. It's a condition that we now recognize, something that we call clonal hematopoiesis, or CHIP. And these blood cells, we can detect them because we can detect these genetic changes when we look at the genes in the blood. And sometimes these cells then go on to get another genetic change, so represented by this blue dot here. So now this cell has 3 different new changes in it. And this one now is actually a change that transforms that cell into a cancer cell. And then that one can take over and progress into an even more aggressive malignancy like acute myeloid leukemia over time. So this is what we're beginning to understand is the process of how myelodysplastic syndrome develops. So many patients want to understand why they develop this disorder. And sadly, for a very long time, we most of the time tell them, well, it happens by chance. We don't really know. And so it's very satisfying that over time, with a lot of research, many people have helped to unravel how this process is happening. But also some other experts, like myself, we are involved in something called a cancer risk assessment. And so the people who do these cancer risk assessments, their goal is to try to help a patient understand if there were particular risk factors, whether they're exposures that they've encountered or inherited genetics that might have contributed to why that person developed MDS, whereas another similar person did not. So the people who do these kind of evaluations are specially trained hematologists or oncologists or cancer geneticists. So these are people who have studied genetics and use it in the clinic. There are also a group of health professionals called genetic counselors. And these professionals specialize in cancer or in prenatal counseling sometimes. So people might have encountered them in that scenario as well. And they are experts at helping to pick out the genes that make someone at risk for a particular disease, help the people get testing for those genes, and then interpret how it impacts their future health. So the things that we do during a cancer risk assessment are ask about exposures that we know might have impacted that person's potential to develop one of these cancers or health disorders. We ask about the family history because that can give us a window into both exposures as well as genetics. And then we think about whether genetic testing can help, or if it's already been done, how to interpret it for the patient and help the patient use it to improve their health. So why do we do this? Well, this process can sometimes change the treatment. If we understand that there's a particular gene that has caused a cancer in a family, it can change treatment and help us with sometimes personalized prevention for other family members or for other cancers that might happen to the patient. And we'll go through examples of this today during this talk. So to give you a little bit of the historical perspective of cancer genetics, this field really was best established and is best known for breast cancer, ovarian cancer, and colon cancer, where this has been studied for many decades now. The first genes that were known to increase the risk of particular cancers if somebody carried them in all of their body's DNA, which we call the germline or inherited DNA, these first genes were discovered in the early 1990s, and we could test for these genes, and we usually did it by a one gene at a time approach. There were some major developments in 2013, which isn't that long ago, where the public really became much more aware of this field of inherited genetics and how it can impact somebody's health. One of these was from Angelina Jolie, here pictured on Time magazine, talking about her own experience with her mother dying of ovarian cancer and herself getting tested and being found to carry a BRCA1 inherited mutation that led her to do changes to help prevent breast and ovarian cancer for herself. There was also a major Supreme Court decision where germline genes could not be patented, and so that opened testing to many more labs and allowed us to then offer testing at a much cheaper cost to patients. In addition, technology has dramatically improved, and so instead of having to go small piece of a gene by small piece of a gene, we can now look at many genes in an individual at one time. So some examples from how this information can help from the breast and ovarian cancer world. If a woman is found to carry a BRCA1 or BRCA2 mutation, we offer them options like preventative surgeries to remove the breasts or ovaries, which can dramatically decrease the risks of developing breast cancer and ovarian cancer. And these interventions over decades of research have been shown to not only prevent cancer, but they help women live longer. And so obviously this is the goal of what we do, and prevention is the really important goal at the end of all of this. So what about patients with myelodysplastic syndrome? Is there hereditary myelodysplastic syndrome? Well, this is an actual family where there are multiple cases of myelodysplastic syndrome or its close related disorder, acute myeloid leukemia, all within a family. And this family had been told multiple times by their hematologist that there really weren't known hereditary MDS or AML conditions for adult patients. And this was a very long established assumption in the field. And so really most people, including hematologists who patients will encounter, have been taught that hereditary MDS is extremely rare. So if we kind of draw it out here, this rare person in red here is the single person among many, many MDS patients that we thought potentially could have a hereditary form of MDS. Well, fast forward to 2016 and 2017, this has dramatically changed, where we now understand that hereditary contribution to MDS is much more significant than we realized. And this has led to a change in guidelines. So when a hematologist is looking at the official guidelines of how they should take care of a patient, the National Comprehensive Cancer Network now has included that they have to think about whether their patient, each patient, has a hereditary form of MDS. In addition, the World Health Organization has established guidelines for diagnosing and classifying someone's myelodysplastic syndrome into specific subcategories. So they're listed here, and your hematologist at the time of MDS diagnosis puts you into one of these categories of the subtype of MDS. And now the pathologists have to also think about whether that MDS was actually due to an inherited disorder. So a lot of research has gone into changing this assumption, and we're going to talk about some of that today. So the first step in trying to figure out if someone with MDS could possibly have an inherited component is to also look at what other risk factors do they have. So one of the biggest risk factors for MDS is older age. So the average age of MDS diagnosis is around age 72. So for someone who falls in that age range, that's the very typical age and expected age range of having MDS. Our patient, however, was 42. That's much, much younger than expected. So already we're thinking, could there potentially be some other contributor to why this young woman developed MDS? We think about exposures. So we know that chemotherapy, radiation, and some chemicals like benzene increase the risk of myelodysplastic syndrome. So if those are present, we pay attention to that because we then understand that could potentially have contributed. Smoking may also contribute. Different risks seem to be different across racial groups. So with Caucasian patients having a higher risk of MDS than other ethnic backgrounds. And males, MDS tends to happen to males more often than females. So next, we look at a family history, and this is how we draw out a family tree in cancer genetics to try to look at the relationships and types of cancers or health conditions that exist within a family. So here's our patient. Girls and women are drawn as circles, and we fill them in when we know that they have a particular blood disorder or cancer that we're interested in. And so she has MDS at the age of 42. She actually knew a lot about this disorder because she helped care for her mother, who had acute myeloid leukemia at the age of 56 years old and unfortunately passed away from that diagnosis. She also knew that her grandmother had had a low blood count, and they weren't sure quite more details about that. Her ethnic background was Irish and German on that side, and her paternal ethnicity was Mexican. And there was limited information about his extended family history. So when we look at this type of pattern, this definitely suggests that there may be a familial clustering of these myeloid blood disorders and increases the chances that this particular family might have an inherited component to why she developed myelodysplastic syndrome. So how often do patients coming in with MDS have this kind of family history with other close relatives with a blood disorder? Well, you can remember that I told you we assumed that, this was very uncommon. But when we actually did this study, and 3 other groups now have published this as well, about 1 in 8 total patients will have another close relative with a blood cancer. So this is not so rare. This is pretty common actually when we ask patients. They will say, yes, my other family member had a similar disorder. So what kind of family history patterns can give us a clue that there's this inherited component? As we saw with our patient, 2 or more close relatives who've had blood cancers or low blood counts where there's not an easy explanation can suggest that. In addition, people or families who have multiple cancers. So let's say our patient instead had breast cancer at the age of 30, got treated for that, then developed thyroid cancer, and then eventually developed myelodysplastic syndrome. This is a very young woman who's now had 3 cancers, and that suggests sometimes that there's an inherited reason. In addition, a family like this, where instead, here's our patient with MDS who's young, her mother had breast cancer, her uncle had pancreatic cancer, and her grandmother had ovarian cancer all on that side. This pattern of cancers is highly suggestive in this clustering of one of the solid tumor genes that we think of, like BRCA2, for example. And sometimes we do see blood cancers in those families. And so this family pattern would again prompt us to consider doing genetic testing. There can also be other factors in the patient's history or their subtype of myelodysplastic syndrome that can help suggest an inherited component. So as I mentioned, young age at onset. So basically anyone under the age of 45 who's diagnosed with myelodysplastic syndrome, we now think about doing genetic testing because about 10 to 15% of them, we can find an inherited reason why that happened to them. We also look for other history findings that can suggest that one of these genes is present. So there are some disorders that can cause gray hair to happen before the age of 25. There are some that affect the immune system, and so the patient can have multiple infections over their lifespan or unusual types of infections. Some patients can also present with developmental anomalies where a body part like their thumb was not formed correctly, or they have a heart defect or other body part defect that might help us understand that one of these syndromes is present. In addition, things like specific disorders of the lungs or the liver called pulmonary fibrosis or liver fibrosis or cirrhosis without another cause also can sometimes suggest one of these disorders. There also can be patterns of the genetic changes that have happened in the MDS itself that can give us a clue, and we'll kind of talk about that in more detail soon. So here we have our family where we would give this family a potential clinical diagnosis of a familial MDS and leukemia syndrome. But this family, where there's a child who's developed MDS at the age of 8, now this is 7 decades too early from the usual population age at onset. And so this patient also has a familial MDS, but here you don't see any family history. Same thing with this gentleman. He's 75 and has MDS, and he also has a hereditary form of MDS. So the point of this is that when the family history is known and is present with multiple generations affected by a MDS or a low blood count issue, that is very helpful. But when it's not present, there still can be a familial syndrome. And so when we look back at this map, what we've learned is that when we go and find people who have these inherited disorders, there's a substantial subset, about half of them actually don't have any family history of these disorders. And so they would remain undetected if we only used family history. And so cumulatively, this ends up being about 20% of patients with MDS have an inherited disorder, and this varies by age group. So this is more common than we think. Family history can help give us a clue or some of the other health conditions that a patient might have. And let's say we decide that the patient needs genetic testing. So for our patient who was 42 with MDS, she meets the criteria that she's under the age of 45. And so this is a disorder that normally shouldn't happen to 42-year-olds. So we're going to do genetic testing, and her family history adds further weight to wanting to do that workup. So then how do we go about deciding what gene is actually involved? So for those of you who have not done genetics training, let's start by looking at what is a gene. So inside our body, all of our cells have DNA that is contained on chromosomes. So these are packed into our cells, each of our cells in their nucleus, and they have coiled up DNA molecules where these bases are A, C, G, and T, and they pair, and they basically form a recipe for these proteins that are the worker bees inside our cells. So these proteins have all sorts of important functions, and this DNA is the code that tells the body how to make this specific protein. So we are able to look at these, the sequence of these molecules within the genes. And the genes are the parts of this DNA that encode for a protein. So there are lots of other parts that don't make proteins. And right now we understand that there's approximately 25,000 or so genes in our bodies. And in the past, we looked at one gene at a time. So we would take a small portion of each gene and amplify it and read the letters. And then we would stick all those pieces together to look at a single gene. And that's time consuming and expensive. And so we really were only able to look at one or two genes at a time. Now, however, we have new technology where we can actually sequence many, many genes at once for a much less expensive cost. We can even look at somebody's whole genome, which includes genes and other parts of our DNA that aren't necessarily a gene. And so this makes it much more feasible then to try to figure out new genes that potentially are causing health conditions. So each of us has a unique DNA sequence, but almost all of our DNA is actually the same. So if you see here, all of the letters that aren't highlighted are exactly the same between these two people. However, each of us has a small portion that differs from other people. So these are highlighted here and here in this particular DNA sequence. And we can read these and interpret those. And so a lot of those changes will actually be common changes where many people have the variant. So here pictured as these little red squares, these are all the people that have that one particular change at that site, whereas others don't. And these are less likely to cause rare syndromes because we assume that if it was a very strong syndrome, that should not be present in all of those people. And so the common genetic variation in general, we think has less large effects on our health than the rare changes. And so we are looking often in this situation for rare changes in our DNA. So these are things that very few people in the population have. So here there's just one person in this group of people who carries this very rare variant. And because this disorder is rare, we then have more likelihood to believe that these rare changes cause these rarer syndromes. We then try to understand the effect of how changing that particular letter affects the protein. And so you can think about it like these sentences. So the original sentence, the gray cat ran down the hall, if you change one letter, you might change the meaning a little bit. The gray cat ran down the ball now. And so that's called a missense change. We also can have parts where extra letters are inserted in our DNA sequence, or parts are deleted, or they're actually duplicated, where this part gets repeated again, or parts are entirely missing. So this is called a nonsense change. And obviously that's the biggest change that we see here because a lot of the sentence is missing. And so we are able to interpret when we're doing this genetic testing what the effect of changing a particular DNA sequence does on the gene and its protein, and that impacts how we interpret how likely it is that that genetic variant causes a particular disease. So when we do genetic testing, the three outcomes are positive. We found a damaging genetic change that we think is the explanation for somebody's health condition or blood cancer. Negative, we didn't find any damaging changes, so your DNA looks just like the majority of other people, or something called a variant of uncertain significance. And this is a rare genetic change that we don't yet understand how it affects that gene or protein. So these are the most challenging for the field because we don't use these to change somebody's healthcare yet because we're not sure if they do anything bad to the protein. And so these are something that a lot of research is going into, trying to understand what impact those rare genetic changes have on that gene and health conditions. So there also are many opportunities in our clinical scenario right now to understand the difference between inherited changes or acquired genetic changes. So inherited genetic changes are something that somebody is born with, a change in their DNA that's different from most other people in all of their body cells. And so as you're forming as an embryo in your mother, these changes are passed then to every single cell as your body grows and divides. And they can also be passed on to future generations. In contrast, as we live our lives, our bodies are exposed to lots of different things. And because of cells dividing or because of being exposed to things that damage our DNA, we acquire new changes to our DNA that are only in certain cells. And so let's say we have a mutation that happens in our skin because of a lot of sun exposure. Well, then the only place we're going to find that change is in those skin cells if we were to test those skin cells. And so here, this is depicted by these little red arrows, and different exposures can cause more of these mutations. And right now, we think that it takes multiple different genetic changes to all accumulate in a single cell in order for us to develop a cancer in most scenarios. And so let's say we took a cancer sample, like in MDS, we took somebody's bone marrow sample that's affected by the MDS, and we did genetic testing from that sample. That will include a mixture of both inherited and acquired genetic changes. And so we then can interpret those changes, but we're not sure if most of them are probably acquired, but there might be one or two that are actually inherited genetic changes, and we have to use different samples to try to figure that out. So as we talked about at the beginning, acquired genetic changes are important for MDS diagnosis. And so the changes at the chromosome level, or if we zoom in and look at the gene level where we're reading the individual letters of the genes, both of these are very important to understanding someone's MDS and how it will behave and whether we need to do a stem cell transplant, for example. So this is a map of common genetic changes, whether at the chromosome level or in the individual genes, and how frequent they are in a group of patients that have all been tested that have MDS. So for example, losing chromosome 7, so that would be this chromosome right here. So if you only had one copy and one of these was missing, that can be present in up to 15% almost of patients with MDS. And so that's pretty common. There are other genes, and this is a huge long list, that are either common or more rarely acquire changes as a process of the MDS happening. But when we look at the individual genes, for example, a gene called RUNX1 or another gene called P53 that are relatively common in patients with MDS, these genes actually can cause inherited forms of MDS to happen. So when we just sequence the MDS, it's hard for us to know as a doctor, is that something that just was acquired and is only in the cancer cells, or is that change in all of that patient's body cells? And we can estimate that about 1 out of every 5 patients, when we sequence their MDS, will have a mutation that could be a familial MDS mutation if it were in all of their body cells. And so we've been trying to figure out how do we figure out who has an inherited form and who doesn't? So in order to help us figure that out, we have to take a different type of different type of sample. So we will use a skin sample, for example, where we take a small, tiny little biopsy of the skin and we grow it in the lab, and then we test the DNA from that skin, because the skin is not part of the bone marrow or blood that's affected by MDS. So this is trying to get at the DNA that is more representative of the DNA in all of our body cells. So we've learned that there are multiple different inherited disorders that we can find in patients with MDS, some of which we understand much more directly cause an increased risk of myelodysplastic syndrome, and others which we think may contribute, but we're not quite as sure yet. So some of these include genes like we talked about earlier with breast, ovarian, and pancreatic cancer like BRCA1 and BRCA2. And these have traditionally been thought of as only causing an increased risk of solid tumor cancers like breast cancer or pancreatic cancer. But when we see blood cancers in those families, it makes us wonder if those are more directly involved in risk of developing MDS as well. We also see some syndromes that are thought to be more often presenting in childhood, but we're learning that adults can have them as well and just not have a lot of the other features that make pediatricians recognize that they're present. So these disorders are names like Fanconi anemia, which is a bone marrow failure disorder that increases the risk of myelodysplastic syndrome. And then there are genes that we've only more recently learned about that really only seem to increase the risk of developing a blood cancer and don't have other health conditions associated with them. And so people are perfectly healthy until developing a blood disorder, and these run in the family. So some of the typical ways that these are passed in the family, the most common pattern is called autosomal dominant, where you only need one abnormal copy. So this person here has MDS. They carry one abnormal copy of this gene, and each of their children has a 50-50 chance of inheriting that. So unfortunately, this gentleman's children each inherited his bad copy that had that mutation rather than the healthy copy. And here the mother's same chromosomes are being transmitted and don't carry this. But one copy is enough to increase the risk of developing MDS or health conditions related to these genes. And so some of the genes that can cause this are listed here. And as hematologists, we're learning to recognize the different health effects of carrying one of these. It's important to know, though, however, that even people who carry one abnormal copy, it's not a guarantee that they're going to develop MDS or any of the health conditions related to it. So some people say, well, am I doomed if I have this genetic change? But currently, we don't understand the trigger to going from having one of these genetic changes to actually developing a blood cancer. And that is a very active area of research so that we can identify ways to stop that process and prevent MDS. Another inheritance pattern is autosomal recessive, where a person needs two abnormal copies of that same gene to develop the disorder. And so here, this child inherited one of those copies from dad and one of those copies from mom, and then is affected by the disorder, where both the mom and the dad are said to have a carrier state. So the one abnormal copy is not enough to cause the health condition. And a typical syndrome is Fanconi anemia, which I mentioned earlier. This other sibling here inherited two normal copies, so is not at risk for having that disease and is not a carrier of that disease. So there are many disorders like I listed, and within each disorder, so even within Fanconi anemia, there are many genes that we consider that could cause that gene. And so nowadays when we do genetic testing, we're often testing many genes at once because it's sometimes hard to figure out, is it this disorder or that disorder just from the clinical history. So our patient actually had this testing, and their clinical story, as I mentioned, was a familial MDS diagnosis. The patient also had a mild bleeding history with extremely heavy periods throughout most of her life. A gene panel was done from her skin cells, and she was found to carry an inherited RUNX1 mutation at this particular site in that RUNX1 protein. So she actually has a diagnosis of familial platelet disorder with propensity to myeloid malignancy. This is the name of the disorder. It is autosomal dominant, so she only carries one abnormal copy of this, and each of her children has a 50-50 chance of inheriting it. Other symptoms that she has are low platelets that do not work properly. So this disorder, the platelets not only can be low in number, but they don't work as well. And individuals who carry a RUNX1 change in all of their body cells have about a 40% lifetime risk of developing leukemia. So this is much, much higher than the general population. And so this is how we sometimes will see it then being passed, where MDS is happening to multiple individuals within a family in multiple generations. And the age that these cancers happen are somewhere between childhood or all the way up to 75. And sometimes there are people in the family that we test, they carry it, and they die in old age without ever having developed a myeloid malignancy. So again, it's not a guarantee. So how does this actually impact their care? Why would you want to know that you might be at risk for leukemia? And how does that help you? So first, it provides a very specific diagnosis. So sometimes it's very satisfying to have a molecular diagnosis that tells somebody, why did this happen to you, especially when it happens at a young age? It also can help the patient and others in the family really get correct care. So as I mentioned with our patient that we've been talking about, other people in her family actually had a low platelet count. And a lot of times in hematology, that is assumed to be from a different cause, something called ITP, where we assume that it's the body's immune system that's making the platelets low. And one of the treatments for that is actually removing the spleen. And in this situation, that would be the wrong thing to do because it's not going to help, because it's not the spleen's problem. It's actually the bone marrow's problem of why the platelets are low. And so in this family, for example, we can help them avoid that issue. And we can also help them if they're at risk for other health problems. So in this situation, they might have bleeding if they have a procedure or they have a baby. And that's because the platelets aren't working correctly. And so we can help them get platelet transfusions or other therapies that are appropriate for their platelet problem and not treat things that aren't the problem. So in this family, for example, her brother also had mild bleeding issues, and we could then help him avoid getting the incorrect treatment for that. It can also sometimes modify the treatment strategy for somebody's MDS. So for example, stem cell transplants are used. And in some of these inherited disorders, the timing of when we would do it, whether early in the disease process or waiting until there's a more advanced disease, can be impacted by knowing that there's a hereditary syndrome going on. And also it impacts who might be the best donor. So if we're looking to family members like your brothers and sisters to help us be a potential donor, if they also carry one of these genetic changes, we have a careful risk-benefit discussion about, is that the right thing to do? And it varies by gene, what's the best answer. So in some family situations with some genes, we avoid using family members who carry the same genetic mutation because they also have a higher risk of developing leukemia. And so we don't want either the donor or the person receiving the cells to have trouble. We also sometimes adjust the treatments because a patient with some of these germline mutations are actually more sensitive to side effects of chemotherapy and radiation exposure. And so we have to then adjust things, and the genetics help us know what to do. Also, we can change survivorship plans. So if there's a gene that also impacts risk for other cancers or other health problems, like the ones that affect the immune system and make somebody at higher risk for infection, we can then monitor and manage those more appropriately. And thirdly, we can know who in the family is at risk. So some people will be tested and they won't be found to carry the same genetic change and are then told that they're not at a high risk for developing the same health problems. And that can be reassuring. It can also help us provide screening and in some situations prevention. So like I mentioned in the families where sometimes we'll find a BRCA1 or BRCA2 mutation in the family, there are known methods to actually improve somebody's lifespan and prevent cancer for their family members. So knowing that that's there has direct implications for helping other family members remain healthy and avoid a cancer diagnosis. And lastly, these genetics can also be used for reproductive counseling. I've taken care of a number of families where, because of all that they'd experienced with multiple people in the family being affected by blood cancers or other cancers, they actually said, I'm never having kids because I really don't want to pass that risk on. And there are now ways that we can use genetics to help us prevent passing on some of these genetic changes to reduce those risks. So inherited genetics are really being used more and more in the clinic for these risk prediction, for prevention and family planning purposes, where maybe we would change the prescription that we give to the patient for their life to help them avoid cancer. We also sometimes look at the genes to help us understand how they will process drugs, and so which drugs will be more effective or more toxic for a patient. And then more recently, inherited genetics actually helps impact treatment choices. So in breast cancer, ovarian cancer, prostate cancer, pancreatic cancer, we're now using somebody's inherited genetic status to help us pick out which therapy is best for their cancer. And so this is not directly yet involved in MDS treatment, except for in the stem cell transplant setting, but that might come in the future. And so this is a very active area that will only grow. So now when we look at this map, this is really what a lot of us in this field think, that actually a substantial portion of patients with MDS have some inherited component. And some of these will be genes that dramatically increase the risk of leukemia, like the ones I mentioned. And then there will be others that only increase the risk slightly in the general population, but may have contributed to why one person develops leukemia and another doesn't. And we have a lot more to learn. So we're really trying to work on how exactly do these inherited genes cause MDS, because they're a great opportunity to figure out how to prevent MDS, not only for people and families, but for everyone. And right now we're only figuring out about 30% of families who have multiple cases with the current genes that we test in the clinic. We understand a few more on a research basis, but we clearly know that there are other genes out there that we still don't know well, that are contributing to why people are getting these diseases. So the take-home points from this talk today are that inherited genetics are really not rare in MDS. And often my patients are actually educating their hematologists who may not have been keeping up on all that's been happening very rapidly in the last couple of years in this field. There are genes that can impact the diagnosis, and knowledge of a specific genetic cause can impact the care of a patient with MDS. And we still have a very lot to learn, and we're learning a lot from the families who are generously participating in studies. And I am very grateful and have learned a ton from them over the years. So with that, I would like to say thank you and take any questions that you may have.
So the first question comes from Peggy. Why should cells damaged by faulty reproduction take over and not just die out? Why should they be more fit for survival?
Mm-hmm. That's a great question. And, most of them don't. So our bodies have very, very intricate and complicated systems to find cells that have an error and correct them. So there are really extensive pathways in our bodies that protect us from cells that have had a damaged event so that they get corrected. But unfortunately, in some situations, whether it's the type of damage or the amount of damage, some of them escape. And, there are many different pathways that have to go wrong for a cell to really transform into a cancer. That's why most of us don't get cancer, or the people that do, the majority, it happens later in life as these mutation events have a chance to accumulate over time in a single cell. But there are genes, like for example, there's a gene called TET2 that is frequently gets a mutation in it and can live in our blood cells and help those cells survive a bit better. And so we're learning about each of these individual genes and how they impact how each individual stem cell or blood cell can survive in our blood or in our bone marrow, and what makes that cell able to grow better than other cells. And so these are things that are actively being worked on by a lot of scientists.
Thank you, Dr. Churpek. The next question comes in from Corey. Could exposure to benzene increase the onset of a known mutation? I have DDX41 and had MDS in my late 40s, but other relatives have gotten MDS at a much older age, around 80, with the same mutation. Are there any direct studies or therapies for DDX41?
So right now there aren't yet therapies for DDX41 other than usual treatments for MDS. And we see in patients who have an inherited genetic change in DDX41 that the average time that someone develops a blood cancer is around age 62 to 65, like you've described in your other relatives. But sometimes we do see earlier onset cases. So most of the time, not in childhood. We've seen that very, very rarely in adolescence, but most of the time in later adulthood or early adulthood like you. And this is a great question. Why does it change? There were studies years ago that showed a phenomenon that geneticists call anticipation in familial leukemia, where younger generations develop the leukemia earlier than older generations. And when people are trying to do these studies, it's sometimes hard because the families that will stick out and the ones that we'll recognize are the ones where there are more cases. And so having multiple generations affected makes us recognize those families and test them more than a family where people haven't developed leukemia at all or only one person has. So sometimes we're not sure if that process is real, if it's a real biologic process, or if it's something that is an artifact of the way that we find families. But lifestyle factors can also definitely make a difference. And so in MDS, there are known exposures like smoking or benzene that can increase this rate of developing mutations that might further that process. For each individual patient, we often have a hard time pinning those things down, but these are things that we're actively working on. And so right now in the field of familial leukemia, there's a lot of studies going on and opportunities for research where we're following individuals and their whole family longitudinally over time, sampling their blood to look for these mutations that we know sometimes can be a precursor to MDS. And so it's sort of another risk factor that we can monitor in the blood. These things aren't yet standard of care for clinical monitoring, so insurances don't always pay for them. Sometimes we can convince them to do so, but on research studies, we can do that. And we think that might help us help understand which people are more likely in the short term or long term to develop MDS or acute leukemia. And so then can we intervene? And some of these genetic changes actually affect other health conditions. Like we've learned that some of these things that are accumulating in the blood stem cells can cause inflammation in the body or make people at higher risk for things like heart attacks and strokes. And so we're just learning so much right now. And, people who have inherited mutations like your family have been so generous with the field trying to help us all figure out how can we someday understand what this process is doing and how to prevent it, not only for people who have an inherited risk, but also people where it happens randomly.
Thank you. The next question comes in from Elizabeth. Has research found that these gene mutations also could be passed to children, specifically band 11q23, FLT3, IDH1, or IDH2?
So most of those are I'm not sure if you remember this slide, this is where it's awesome to be live, so you can use pictures because I feel like this field needs pictures. It's hard to visualize otherwise, but we have two different kinds of changes that happen in our body cells. So inherited are ones that are in all of our body cells. So these things happen when either, we inherit it from mom and dad, or happen to us as we're forming as an embryo in our mother's uterus, but the acquired ones are things that happen over time. So they're only in the cells where that change happened. So I gave the example in the talk of our skin, for example. So if we're out in the sun and we get lots of sunburns, the skin that is sunburnt can acquire mutations. And we know this because there are really cool studies where we take little skin biopsies and we look and we see what happened to those skin cells. And we see mutations that look like cancer mutations, but the body is able to control those through its immune system and through fixing other things like these DNA repair pathways. But for these other ones that you're describing, those are classic genetic changes that are acquired in body stem cells that we see at the time of acute leukemia or MDS. And some of those now have treatments targeting them. So IDH1, IDH2, we first knew about them as genetic changes that were relatively common in MDS. We also see them in other cancers like brain cancer, for example. And now we have drugs that can help target that specific issue, and they are working to help control the disease when you've already developed MDS or leukemia. And now people are trying to fine tune, well, when is the right time to be using those, with what combinations and these things to do even better. So learning about these genetic changes helps us understand the biology of why that mutation is causing that cell to act the way it does and cause a cancer or contribute to the way it behaves. And now, really cool, we can target those with drugs that help control the disease and help people do better.
Corey has another question. Are donors for SCT screened for any known mutations?
So that's not standard of care. Only a couple years ago, my mentor, Dr. Lucy Godley, and I, and a couple other of my team members at the University of Chicago, we made a commentary about the unrelated donor stem cell transplant policies. They didn't even include asking about family history in their recommendations for how donors are screened. And so these things are rapidly changing as we realize the contribution of inherited disorders to how these, who's at risk and what the outcomes are like with transplant. We still have a lot to learn about how each of these individual genes that people have inherited impact a transplant. And so it's very much an individualized decision based on what we know or what we don't know about how that would impact stem cell donor transplant. But it is definitely becoming much more widely recognized that it's important to screen donors and families to understand whether there could be an inherited cause so that we can make the best decision for that family about who is the ideal donor.
Thank you. I see a question coming in from Karen. My sister was recently diagnosed with lymphoma, and I have MDS 5q minus. Is there any genetic relationship between non-Hodgkin's lymphoma and MDS?
So there can be, and on Tuesday, actually, I'm giving a similar talk, but to a broader audience of blood disorder patients for the Leukemia and Lymphoma Society. But sometimes in families, we see a mix of blood cancers. And so I have this picture that we use in our training for blood doctors of kind of the tree of how you start from a blood stem cell, and below that, those cells divide into different types of cells. And so MDS is kind of a stem cell-like disorder. Lymphoma is usually from a more mature cell that is in the lymphoid branch of this tree of life of our blood stem cells. And so they are related because they come ultimately from the same population, but the problems occur in a different cell population in our body. So lymphoma cells usually are cells that are no longer in the bone marrow. They're most often in other parts of our body, helping protect us from different kinds of infections and things. And those cells can, if they get the errors in that cell population rather than in the stem cell that's in our bone marrow, you can get a type of lymphoma. And so each of the blood disorders that we understand, we're starting to learn more and more about the exact cell that they start in, and that helps us understand the biology and treatment. So your question is, yes, they can be related. And some of these genes, like DDX41, can cause both MDS and lymphoma. But the genes for families where there are multiple people with just lymphoma, we know some of the genes, but in some cases, we don't know the genes as well as we do for familial MDS.
Thank you. The next question comes from Sherry. My great-grandfather died from leukemia, and my first cousin has CML. I was diagnosed with MDS in 2015 at the age of 58. Could this be familial? My father had low platelets, and he was actually told he might have had MDS.
Absolutely. So I would help do a panel-based genetic test to try to understand if that's the case. And there's a number of genes I can list off. And sometimes, when I'm doing the evaluation, people sometimes have some of those other health conditions. There's a whole bunch of them. And the part of my job is pattern recognition and family histories. And so the more information you can get about your family, what age did they start having trouble with their blood? Did they ever have low blood counts, even when they were a young person? Did they have bleeding? So nosebleeds, bleeding from their mouth, bleeding after surgeries or childbirth that was part of their story. These are all things that help me better advise somebody about which disorder is more likely in a family.
Thank you. A question just came in from Anna. Is there any information regarding HTLV causing MDS?
So that is a virus, and there are some links to that virus to specific kinds of leukemia, most often a different kind of leukemia, a lymphoid-based leukemia rather than MDS. So I don't know that there's a strong link to MDS. most of the viruses that we understand are better understood to increase risk of lymphoma and lymphoid types of leukemias so far.
Thank you. The next question comes in from Sheila. My husband has preliminary MDS. For years, he has had low red cells, white cells, and platelets. What's the chance of him developing full-blown MDS? He's 73.
So I think it's hard for me to know without looking at the details, but I think sometimes the patient's own story and their own history help us understand that. And now we actually have other tools in the clinic that can help us. So if he's had 15 years of pretty stable low blood counts with a bone marrow that sort of looks a little bit abnormal like a pre-MDS, his own history has kind of taught us about how it's behaving. So while anything could change any day, we can't predict that for 100% on an individual patient basis, but it's more reassuring than, he had normal counts last week and now all of his counts are low and they're getting lower by the week. That's a different situation where the risk of transforming is probably more likely than somebody where you have a long history of monitoring and things really haven't changed. That makes us feel a lot better than the other scenario I described. And now, just as I was talking about monitoring the blood for these acquired changes in specific genes that we know are leukemia or MDS-like that we can have in the blood without actually having MDS, sometimes the pattern of those mutations can help us predict for an individual patient what's the likelihood that you'll develop MDS in the next 2 to 5 years versus someone else. So there was a really large study done out of Italy a couple of years ago where if we found a pattern of 3 or more of these mutations or mutations in specific genes like U2AF1 is one of them, for example, if you have those, your chance of going from low blood counts where you don't yet have MDS to actually developing MDS was much, much higher. So there were groups of patients where within 2 years, 50% of them would progress to MDS. So if you had none of those mutations, the risk was much, much lower, where years and years people were followed without developing MDS. So, one of the big areas, another big area that people are very interested in is, can we be very precise about the diagnosis of MDS? Because there are lots of people who have chronic low blood counts where we just don't know exactly why they're that way. And obviously we want to pick out the people who have a high risk of developing MDS, especially if it's going to happen soon, because then we might be more likely to take risks and intervene than people where if we knew and we had a crystal ball and we could really predict really well that you weren't going to develop MDS, for 20 years, we're not going to jump to something like a stem cell transplant where there's risk doing that if it's not warranted.
Thank you. The next question comes from a CMML patient. I have a GATA2 P161A, which is germline. My son has the same mutation. My question is, can he still be a haplo donor when I need a transplant, or do we need to find another donor?
So that's a really specific question. And the specific genetic change you have in GATA2, I would personally look up because I have in my memory that one may not be a damaging genetic change, but I would have to look at your genetic report to really tell you for sure exactly a lot of details about your genes. So as I was kind of demonstrating in that presentation, we sometimes find genetic changes in these genes that we know cause hereditary syndromes that we call variants of uncertain significance. So they are changes that are different than the majority of people out there, but we don't yet really have clear evidence that that change is actually damaging the function of that gene. And so when the variants fall in that group, it can be very frustrating for the patient if they're like, well, do I have the syndrome or don't I have the syndrome? But it's very important for us not to label somebody with a syndrome if they don't actually have it. So a lot of times we work very closely with families and with a large network of researchers who are working on these syndromes to really nail home whether that impacts the function of that genetic change or not, because that is critical for us following your family and deciding what other things should we be doing for you? Obviously, if you have GATA2 syndrome, which is for patients who have damaging changes in that gene, we watch the blood very carefully. We watch your immune system very carefully because people can develop immune system problems where they're at risk for different kinds of infections. There can be other health disorders that I won't list here, but and then the stem cell transplant donor situation is then very nuanced. If we know it's a damaging change, most often we won't use that person as a donor. If it's a variant of uncertain significance, there's no other donors available, we might consider it. And so this is where it's a very personal and very detailed assessment for each individual patient. So I can't give it to you in exact answer right now without looking at everything in extensive detail.
Thank you, Dr. Churpek. The next question comes from Marietta. Is TP53 associated with increased risk for other cancers in addition to my MDS and breast DCIS?
So P53 is a gene that I know very, very well from taking care of patients who have a genetic change like that in all of their body cells. Those patients have a syndrome called Li-Fraumeni syndrome. So they have one normal copy of the P53 gene and one abnormal copy that doesn't work correctly. And that syndrome has a very high risk of cancers. For women, about 90% of patients with classic Li-Fraumeni syndrome have cancer by the age of 40. For men, it's about 70%. And the types of cancers are basically anything can happen, but the most common ones are breast cancer in women, brain tumors or sarcomas, which are cancers of the muscles or bones or soft tissues. And so that syndrome is a very specific syndrome where we have a very rigorous follow-up plan, and we do things like whole body MRIs where we are looking in the whole body to screen for tumors before someone has symptoms so that we can treat them and get rid of them before they are life-threatening. Leukemias, lymphomas, MDS can all happen in Li-Fraumeni, but they account for only a small percentage of the cancers that happen in people who have that syndrome. But more commonly, P53 is super, super common in every cancer. So it is considered the guardian of our genome. It basically is one of the signals that our body's cells use to say, hey, stop this cell, it has a problem and it needs to be fixed, or else I'm going to kill that cell. Sorry, there's something floating around. So P53 is super, super important gene in our cells. And if you take any cancer, when they take the tumor and they sequence the tumor, many, many cancers have an abnormality in P53. In MDS, P53 genetic changes are acquired in about 30%, up to 30% of tumors. So especially advanced MDS or MDS that has happened after chemotherapy for another medication or cancer. And so P53 is just super, super common in the cancer. So most people who have a cancer that has P53 changes in it, that is not in all of their body cells. It just happened in the tumor. And so that patient doesn't have Li-Fraumeni, they have a P53 mutation in their tumor. And I see a lot of patients like this where we're trying to figure out if that's the case. And one of the slides that I had in my slide deck was basically describing that. If we just sequence tumors, we find a list of things that if they were in all of the body cells would be an inherited disorder. For most people, they're not. They just happened in the cancer. But figuring out who those people are can sometimes be tricky, especially if they have a small family or the disorder does not have a high risk of problems. And so people can carry the genetic changes without having any symptoms, only to have another family develop multiple problems. And so this is where the field is trying to get better at figuring out who really needs to be assessed for these. How do we do it efficiently so that we can make sure we're taking care of people in the short and long term the best.
Thank you. The next question comes from Tammy. Should I have my 25-year-old daughter be tested? Would it benefit her for future wellness?
So tested for what is the question? In general, the field does not like to test children for anything that is not a childhood onset disorder. So for example, DDX41, we would have a really hard time and a really careful discussion before ever thinking about testing a really anybody under 18, especially for that disorder, unless the family history warranted it. Because if you're not due to potentially get a blood disorder until you're in your 60s, why put that burden on an adolescent where it doesn't really impact anything during that time period of their life usually? There are other genes, however, that do impact cancer risk. So, for example, leaf Romani, like we just talked about, cancers can happen, anytime. So infants even. So we test kids for that gene because we do something different about it. We screen them. We have a prevention program for them. So it really depends on what you're asking about. In the hereditary cancer world, like I kind of described in the history, there's a lot of really important people out there who do research in this field, especially in breast cancer, where people have said, well, why don't we just test the whole entire population, especially women, for gene mutations in genes that we understand well, like BRCA1 and BRCA2, where we start screening and prevention at the age of 25. So we already start mammograms and MRIs at that age. This is called population screening. So instead of selecting people because of a family history or a personal history, we're just testing all of the people in the population. And that's very controversial because of cost and what if it's not going to manifest? And, the way we learned about families with hereditary disorders is by finding people's families who had the strongest picture, right? We looked for families where there are 4 or 5 people with breast cancer, and that's how we found breast cancer genes. So when we start testing people where they don't have a family history, does that gene change mean the same in that family as some family where there's just tons of cancers? And what we've learned a lot about is that it's complicated. So sometimes it's not just one gene that's going on in those families, but 2 or 3, and it can be really complicated. And so we're continuing to try to figure this out and extrapolate it to more people. But, I would say, what are we testing for? What's the goal? And the only goal of testing in that situation is if it's going to change that person's care in the near term. So can we get information that will help your 25-year-old with screening or prevention? And what are the other options? So reproductive issues sometimes also in that age range where we're saying there's this gene that's running in the family that could impact her decision making about having children with a mutation, and she wants to understand that risk. And so sometimes we think about testing for that too.
Thank you. Felix wants to know, as a musician, he played in many clubs over the years and he never smoked. And in the club, there was a lot of smoking going on. He was diagnosed with MDS in 2013 at the age of 70. Would that possibly have had any effect? Also, have had 2 bone marrow biopsies who haven't shown any signs of possible leukemia.
Okay, so, secondary smoke definitely is a risk factor for multiple different cancers. And so obviously the amount is a little bit harder to quantify than we know for people where we ask them things like, well, how many packs of cigarettes a day did you smoke for how many years? We can quantify that better because most people who are smoking themselves know the quantity of smoke that they're inhaling. So when we have people who have secondary exposures, definitely that has been shown to impact cancer risk. So for example, flight attendants advocated for no smoking on planes because they were getting other cancers from secondary smoke exposure when it was okay to smoke on airplanes and things. So for sure, secondary exposures can impact our risk. It's just we have a harder time quantifying exactly what amount someone has been exposed to. So it's harder for us to apply some of the screening and prevention stuff. So for smokers, for example, if you've smoked more than 1 pack per day for 30 years and you're age 54 or older, there are really the U.S. Preventative Services Task Force and others have guidelines for annual low-dose lung CAT scans to find small lung cancers early because it's been shown to improve survival and it works. But it's harder for us to apply those to people who have things like secondary exposure because it doesn't fit the things that people who went on these trials had to fit in order to go on them. So, this is where people in my field, sometimes this stuff is more of an art than a science and trying to figure out how to apply that when your patient doesn't fit the exact scenario. So the answer, I guess, is potentially, obviously, now it's hard to take that back. So looking out and making sure that you avoid those exposures if you can is important.
Thank you. Carol is joining us from the UK. Her father has been diagnosed with MDS. Is genetic testing widely available in the UK?
That's a great question. So I have colleagues in the UK who are actively working and thinking about this question. There is a researcher named Jude Fitzgibbon who has a group who's been studying familial leukemia for quite a long time in the UK. And there are other centers of excellence for the MDS Foundation, Dr. David Bowen and others. So there's a lot of experts in MDS in the UK, and the NHS has different rules that I don't know the exact details of what exact genetic testing is allowed or for each individual patient. So definitely your personal physician will know more details of what exactly is available. But I would say inherited genetic testing is becoming more and more available to people through companies that sometimes offer even helping send saliva kits to a company in the US for people in other countries if they can't get access to what they need. But there are fantastic genomics researchers in the United Kingdom who are doing this work, and so I would bet that there's access.
Thank you. This question comes in from Leah. Should ET essential thrombosis be evaluated by geneticists in a 21-year-old?
So that's a very young age of onset for essential thrombocythemia, and I have patients like this in my own practice. The genes for hereditary forms of ET are definitely much less understood than some of the ones I've talked about for MDS. We definitely look for them sometimes, especially if there is a family history. And there's no downside necessarily to looking and seeing if you can find something that makes sense. But frequently we do the testing and it's negative, and then we still are left wondering, like, why did this happen? And that's where opportunities for research are definitely something that I highly encourage anybody who wants to help move this field forward. If you're a patient and you have a situation like that, you definitely can get what is standard of care clinically, but then if that's not providing an answer, find avenues to participate in research, because sometimes over time we figure it out. And, I've had the pleasure of working with families where we're like, we don't know what it is, but over a couple of years, we figure it out when we can actually go back and tell them, like, this is what it is, and this is the name at least. We don't know everything about it, but we're going to continue to keep working on it. And, we often partner with families. So we hear about their updates to their family and understand what's been happening. Is there new cases? Hopefully not. But this is the standard of care that we have now, and that changes and more rapidly than you'd think.
Thank you. The next question comes from Lisa. Have you identified any specific triggers for MDS linked to specific gene mutations?
So that's a good question, and that is what we're all trying to figure out. I think the current state of what we understand is that it really varies by the specific gene. So the best examples that we understand are in situations where there are specific bone marrow failure conditions. And it just has taught us that the body is really amazing at trying to deal with these issues. So for example, there's a gene that makes it hard for the bone marrow to grow blood cells. And it's a change in a gene where you have to have two abnormal copies. And the body actually, by just so much pressure of wanting to make blood cells, eventually an error happens on one of those copies that actually corrects it and makes it go away, and then the bone marrow can grow again. And so we are all trying to figure out and learn from this and see if we can someday help to apply that to help with prevention. But right now, what we think is that, if in some of the genes, often it's acquiring another change on the other copy of that gene. So for example, in a familial leukemia disorder that's caused by one abnormal copy of a gene called CEBP alpha, if you get another damaging change on the other copy, so now you have no normal working copies, that seems to be the trigger to overt leukemia in some cases. but what actually causes that specific damaging event and how that process happens in an individual cell, we don't yet perfectly understand.
Thank you. That's all the time that we have for questions. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. If you missed out or would like to revisit this webinar, be on the lookout for an email that will provide you with a link within 4 to 7 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes today's program.